Hey guys, we're back with another video from Improving Birth Abbotsford for 25 days to question your induction. I wanted to warn you guys now that this video has a trigger warning. This covers reduced fetal movements. It covers preterm rupture of membranes, so preterm rupture of membranes, which is different from pre-labor rupture of membranes. I know I said in my last video it was pre-labor rupture of membranes, but I wanted to clarify it's actually preterm rupture of membranes before labor is even going to start, so before 37 weeks. And it's also covering stillbirth. Stillbirth is one of the reasons why we have induction, because if the baby has died, most women actually, are not going to want to wait for spontaneous labor. So if that's something that is going to be triggering to you, I completely understand if you want to skip this video. But before you skip it, I just wanted to remind you again about informed consent. Our last few videos, if you want to rewatch them or send them off to somebody else you think could use them, that would be great. Our first video in the series is the statistics for BC and for, in particular, Fraser Health and Abbotsford. So if you're in that area, you might want to pass that video along to other people within the area for Abbotsford, because we have the highest rate of induction in all of BC at 31.9%. That's almost 1 in 3, guys. 1 in 3 is statistically about 33%, and we're sitting at about 32% as of 2015-2016. I don't know what it is now. I'm still waiting for Perinatal Services BC to update their statistics, but you can always keep checking it out yourself if you want to go on to that website. It is very difficult to navigate, which is why I bring the stats over and make them make sense. But basically, the reasons for induction in Fraser Health are mostly for variations of pregnancy, and I'll get into that in the next video. So if that video is up, you can skip this one and go straight to the next one for variations of pregnancy, or if that video is not up yet, you can go back. I won't be offended. Just please share these videos. It's very important that this information gets out there to as many women as possible and their families, so that we can change the system, because the system is broken and women are not being told their options, and they're not being told the facts, and they're not being told the actual numbers. And if you don't have the information, as I said in my last video, you don't have any choice. So the other videos in our series with our statistics, we have a statistics video, and then we have 3 videos on informed consent. One is about what informed consent is and what it isn't. The next one in the series is about brain benefits, risks, alternatives, intuition, now or nothing. And the last video in the decision making series is the decision making framework. And then after that, we skip into from informed consent into complications, why induction might be offered, and the complications. So there's something wrong with the pregnancy or the baby, or a complication with the mother, that would make induction more likely to be offered. Now, complications in BC and in particular in Fraser Health are very low compared to what induction is actually being used for. We have a 12% rate of, I think it was 12%. I'd have to look it back up. I know it's 16% for diabetes, and I think it's 12% or less for those induced with gestational diabetes, and it also includes the pre-existing diabetes. It's all in there in the Perinatal Services BC. You can look up the statistics for the last several decades if you want. You can just go through their long list of their surveillance. You go under surveillance, and then you go to reports, and you can go through all those reports. And they have as far back as 2011, 2012 to 2015, 2016 in the 2016-17 report, which makes no sense the way they have it, but that's the way it is. So we're waiting for the 2017-2018 report that would have the 2016-17 stats. Anyway, we got complications mostly out of the way. We covered preeclampsia, we covered hypertension, we covered gestational diabetes, we've covered cholestasis, or as they call it, ICP, intrahepatic cholestasis of pregnancy, and we covered pre-existing diabetes. We also covered small for gestational age, or IUGR. They're two different things. I had a whole video on that, including my story, and I encourage you to watch it just if you are curious how I got into this and why it's so important to have informed consent. So now we're going to get into the tougher stuff. This is the reduced fetal movements, and I'm going to try and work through as quickly as I can because I know that this is a tough topic for a lot of people. And if it does get to be difficult, just turn it off. Don't torture yourself. If you need to go back and read it, you can pick up this book, Why Induction Matters. I posted a link yesterday of the actual website that in the UK where they sell this book, and I am I'm making a YouTube channel currently for improving birth. I will be posting the link once I've got some more videos up, and you will be able to find links in the descriptions of the videos to more sources and information if you want to watch it on YouTube. It would be easier also to be able to share links that way, so then more people can see these videos. I'm not too concerned about numbers for viewing for whichever platform you're choosing to use. I'm more concerned about just getting the message out there. So for reduced fetal movement, women start to usually feel their baby move between 16 and 20 weeks. If you have an anterior placenta, it may be a little later. I feel my babies move very early on because I'm a very small person and my babies are very, very active. But other people that may have smaller babies or anterior placenta, so placentas in front of the baby, they may not feel movements until 20 weeks, and that's normal. But basically, what it says is there's no evidence supporting the idea that that movements decrease as pregnancy goes longer, or prior to onset of labor. And the reduced fetal movements refers to a baby who is making smaller movements or fewer movements than is usual for them. So you really need to get to know your baby. They say the use of movement counting or kick charts to basically assess baby's well-being is not supported by evidence. Again, it would vary from baby to baby. So by trying to go on an average and then going by what other people would report, because that's how counts usually work. If it's like, well, I'm only making this many movements a day, that might not be typical for somebody else, but it may be typical for your baby. Not everybody's baby is super, super active. Mine was super, super active. But if you are worried about movements, you can always drink some juice and see if baby starts going a little more active and vigorous, because that tends to happen. They even tell you before your ultrasound appointment, some people do and some people don't. If you really want to see the baby and be able to tell the baby's sex, then you might want to drink some juice or have something sugary before your appointment, just because baby's more likely to open their legs and move around, and the tech's going to be able to get a better view. So it says, in addition to mother's intuition, a mother's intuition should be listened to regarding the baby's well-being, it says. Women become very familiar. Obviously, you're going to know your baby better than your care provider. So if you are concerned, you can talk to your care provider. Tests to assess the baby's well-being would include the CTG and the ultrasound. So basically, the fetal monitor and the ultrasound and a Doppler would basically tell if baby's okay. It says reduced fetal movement is common. 40% of women reporting reduced fetal movement at some point during their pregnancy. And it can be caused by a number of harmless factors, such as position of the baby or position of the placenta. So as I said, the anterior placenta could be an issue, or if the position of the baby is changed. Baby might just be in a more comfortable position and they're sleeping. Or they're just kind of stuck at the moment. After one episode of reduced fetal movement, there's a 70% chance that there's going to be no further complications. Induction is not recommended for a single episode of reduced fetal movement. So you'd have to have quite a few episodes of reduced fetal movement before induction is considered. If they're saying, oh, well, you should induce and you've only had reduced fetal movement once, you might want to get a second opinion, especially if you aren't going for additional monitoring first. Women who experience recurrent episodes of reduced fetal movement during pregnancy are at increased risk of complications, including growth restriction, preterm labor, congenital abnormalities, and stillbirth. Reduced fetal movement can be a sign that the baby is not getting adequate oxygen through the placenta. And if you know from our last video on IUGR, that can be assessed through an ultrasound. So they would likely take you for an ultrasound and they would check the blood flow to the placenta through the Doppler. There's no studies assessing whether induction reduces or the risk of complications for women with recurrent reduced fetal movements. The decision about inducing labor for recurrent reduced fetal movements should be made taking into account other factors, such as whether baby is IUGR and the pros and cons of induction for the individual woman. In addition, if reduced fetal movement is due to problems with the placenta, the baby may encounter the same problems in labor as IUGR. So that's another thing you might want to consider. Now we're going to go into prolonged preterm rupture of membranes. This is different than just preterm rupture of membranes, because if preterm rupture of membranes happens and then you go into labor, that's not the same thing as prolonged. Prolonged would be just amniotic sac breaking before 37 weeks gestation without any further signs of labor happening. So if the amniotic sac breaks after 37 weeks or at 37 weeks, that's pre-labor rupture of membranes. That's not preterm. So the amniotic sac, as you know, protects baby from infection. So if there's a rupture, this is different from a leak. Rupture means the bag's completely broken. If there's a leak, the leak might be able to seal itself. You would basically be in a watch and see kind of situation. Once the membranes are broken, there's a risk of infection of the amniotic fluid to you and also to the baby. So giving the women preterm pre-labor rupture of membrane antibiotics reduces the chance of preterm labor, and it reduces the chance of infection. There's also something called an amnio infusion. It's not so common, but it can work in your case if you have preterm pre-labor rupture of membranes and you want to try to keep baby in a little bit longer than your due date, or not your due date, but your when you hit 37 weeks, you may want to try to keep baby in as long as possible. Maybe try to get it to 38 weeks. You'd be on bed rest and you'd have the amnio infusion, but it's a possibility. I have heard of this. There was a friend of mine who's, I think a relative of hers had it done, and they were able to keep the baby in for a couple more weeks. So in the past, induction of labor for PPROM has been recommended to reduce the risk of infection to the baby. However, a recent Cochrane review does not support this. The review compared early planned birth by induction or planned cesarean for PPROM with waiting for spontaneous labor, and they found no difference in the rates of infection. Early planned birth was associated with increased rates of breathing difficulties for the baby and admission to the NICU. Now, this would be typical, though, of most preterm babies. So it's not so much that you'd really have to look at it as, is this really a case of PPROM, or is this just the case that most preterm babies have this? The review concluded that for women with PPROM before 37 weeks, waiting for spontaneous labor, with careful monitoring improves the outcomes for mother and baby. So if you wait for spontaneous labor, that does kind of improve the outcomes, because then your body's kind of ready to go and your baby's kind of ready to go. Whereas if you're trying to force the baby out, it might cause more complications. Now I'm going to let you know right now, here's the trigger of death of the baby. If you want to turn off the video now, I completely understand. I just want to let you know, please share these. Please go back and share the informed consent ones as much as you can. Go on, if you're on any parenting forums, please share the informed consent videos. They are the most important ones out of this whole thing, because women need to be informed of how they can make decisions and that they actually have the right to make decisions. Because a lot of women that I've talked to have said, well, I didn't know that I had a choice. Or they say, I'm going to 40 weeks and my doctor's talking about induction. How do I go into labor on my own? And my answer to that is, if baby's not ready, baby's not ready, but 40 weeks is early. Stop thinking of 40 weeks as the cutoff. Start thinking of 40 weeks as the average to not so average. Very few women actually give birth at 40 weeks. So I'm going to just say that. And now if you want to turn off the video, you can. I'll wait. Okay, so for those of you that are still here, we're going to be talking about stillbirth. So stillbirth, I just want to say, it's not your fault. There's probably nothing that you could have done, and as much as that hurts, it can also be reassuring to know that it's not your body and there was just something wrong with the baby or the placenta, and you could go on to have a rainbow baby. But it is devastating, and I'm sorry for your loss if you've had a stillbirth. And this is one of the cases where induction of labor was first brought in. This is why it's here, is so that women don't have to wait for spontaneous labor of a stillbirth. Some women will choose that anyway. Personally, if I had a stillbirth, I would choose to be home rather than hooked up to monitors and stuff in the hospital, and I would just deliver my baby at home. But some women, they just want to get it over with, and that's perfectly fine. I completely understand that. And you should know that with induction for stillbirth, it's a little bit different than induction of labor for if the baby's still alive. Because the baby has passed away, you can have the strongest Pitocin drip possible. They're not worried about fetal distress. They're just worried about taking care of you. So they'll make the contractions go as strong as they possibly can, which means you may want to have medication for that. You could have the epidural, and you could have it turned up as high as you need it to be turned up. If you wanted to be pretty much out of it for the whole thing and be on fentanyl, you could do that. You could be on morphine, you could be on fentanyl, you could be sleeping for most of this really quick labor that's going to happen to deliver this baby. And it says many women choose to be induced with their stillbirth baby. So they don't have a lot of evidence between induction of stillbirth and waiting for spontaneous labor. In the past, before induction existed, that's pretty much what you were looking at, is that you had to wait until you birthed the baby. And if for some reason labor never started, that could be a complication where you could get very, very sick. You'd get an infection, and women could die from that. But now we know that you can wait for spontaneous labor until you start to develop problems, and then you could go in for the induction. So it's completely up to you what you want to do. If baby is stillbirth at a lesser gestation, so probably before 28 weeks, so still in the second trimester, you could also consider to do the D&C if the baby is small enough, or you could again wait. But at an earlier gestation, it's called a miscarriage, not a stillbirth, which is still, I would consider those things both basically the same, because it's your baby. Whatever gestation, it's your baby. So decide what's going to be right for you. What's your health concerns about it? And when are you going to consider induction if you're choosing to wait? Some women can just spontaneously deliver their baby and there's no problems, and other women, they could have problems because there may have been problems with the placenta that would make it more likely. There's not a whole lot in this book on stillbirth, but you can always look up the resources. I'm sure that there's some stillbirth support groups that you could join as well. And I think there's an actual organization. I'd have to look it up. I am not familiar with a lot of stillbirth because I mostly focus on pregnancy and birth, of live birth. But I encourage you to look up as many resources as you can. There's no rush on making this decision. The baby is already the baby's demise has already happened. You're just looking at time. How much time do I want to take with this? Some women, they'll find out their baby has died and they'll take a couple of weeks and then they'll decide, or they'll go into spontaneous labor in that time period, and then there's no need for induction. Talk with your family, get some support, get some trauma counseling if you need it. This is a big thing. You can't just go, okay, well, this happened, whatever. If this is affecting you, I encourage you to get some help, because even if you go on to have a rainbow baby, that pregnancy may be fraught with anxiety, and you can develop PTSD, post-traumatic stress disorder, from a stillbirth. I personally know people who had one child and then they had a miscarriage and then they had a stillbirth, and it was for congenital abnormalities and anomalies, and there was nothing that she could have done, but it affected the way that she was able to care for her child, and it affected her after her birth of her second child, and it still continues to affect her today. So get some help. Thank you for watching if you've been watching this far into this video. Our next part is going to be on variations of pregnancy, and I encourage you to share these videos. If you know somebody who's had a stillbirth, you can share this video with them sensitively. If they're not ready to watch it, they're not ready to watch it. But if they are ready to watch it, then it could help them. As I said, I'm just here to help people. I'm not here to tell you what to do. I'm here to give you information. The same information that's in this book and that you can find on the blog Midwife Thinking. So thank you for watching, and we will see you next time. Bye, guys.